So hi, everyone. Welcome to today's webinar. The meeting will be recorded. As a reminder to please keep your cameras off and your microphones muted. The recording will be available to you tomorrow and will be circulated to all those who have registered for this session. And if you have any questions, just a reminder to please put them in the chat room or unmute yourself during the question period. And I will hand it over to you, Divya.
Great. Thanks very much. Thank you all for joining today's webinar, and obviously a huge thank to our guest speakers today. I just wanted to quickly mention who we are. So we are a special interest group as part of AHIA special interest groups, and we're looking at the intersection really between digital health technology and economics. And so I guess the idea of bringing this together was really to provide a platform where we could connect with researchers across different geographies, which would then give us an opportunity to figure out maybe ways to potentially collaborate with others who are interested in topics that interest us. And I think the other two areas we really want to explore together is to identify ways around research gaps to support research priority areas in our own settings. But I think there's also a gap around thinking through methods in health economic research with respect to digital health technologies. And that could also snowball into potentially further down the road for those of us that are involved in teaching and supporting that along the way. So what I'm going to do, in fact, and put in the chat is actually where we are located on the AHIA website. And if you're interested, please don't hesitate to join our SIG, which is our special interest group. And if you have any questions or I guess you're doing some research and want to connect, please reach out to any of us. Our group of conveners cover different geographies. And so there's myself, I am based in the UK, I'm the founder of the SIG, along with my other co-conveners. There's Adriana, who's also in the UK. We have Karsten in Denmark, we have Georgia in Italy, we have Marco in Thailand, we have Lucy in the US, and we have Siabonga in the UK. And so again, thank you for coming, and I'll now hand it over to Georgia and Lucy. Thanks very much.
Hi, thank you everyone for coming. We are all looking forward to learning from our two very esteemed speakers today, talking about telemedicine and AI in healthcare. So structure of the webinar will be, I'm going to give a very brief introduction about the time allocation, and then George is going to introduce our first speaker, Dan, and I'm going to introduce the second speaker, David. Each speaker will have 30 minutes, including about 20 to 25 minutes presentation, followed by about 5 to 10 minutes immediate question after, and then we're going to have an open floor discussion at the end. So now let me hand it over to Georgia.
Hey, Lucy. So I'm very pleased to introduce to you Dan Zatzler, who is a tenure faculty member at Tel Aviv University School of Economics, also affiliated at ITSA and CESIFO. Dan holds a PhD in economics from Princeton University and is currently on leave at Stanford. And his research focuses mainly on healthcare transformation through digitization, new care models, predictive modeling, artificial intelligence, and technology diffusion networks. So please, Lucy, go ahead.
Yeah, our second speaker is Professor David Cutler. David Cutler is the Arthur Eckstein Professor of Applied Economics in the Department of Economics at Harvard, also holds secondary appointment at the Harvard Kennedy School and School of Public Health. Professor Cutler is a research associate at the NBER and a member of the National Academy of Medicine. His work spans so many different areas of healthcare and his household name. Without further ado, let's welcome Dan to present his work.
Hi, everyone. Thank you very much for Divya, Lucy, and Georgia, and all the organizers for organizing this forum in the first place and for having me speak it. I'm very pleased to be here. Let me share my slides. I hope everyone can see this. I'll be talking about telemedicine today. This is an initial assessment sort of motivated by the fact that, as I guess some of you have already experienced firsthand, telemedicine has become much more prevalent since the COVID pandemic and is likely going to be a non-trivial part of the healthcare landscape going forward. And this is a relatively new development. Here I'm showing some data on telemedicine use among Medicare patients. And this is a pattern that has been very typical of many developed countries in the world where, initial pre-COVID, we had sort of telemedicine was always the kind of promise, but due to certain legal, regulatory, and financial constraints, it wasn't a very large share of actual healthcare landscape in terms of visit volume. And this is abruptly changed throughout the world, obviously due to the public health emergency associated with COVID. So this raises the question of now post this pandemic, how telemedicine that has stuck. I mean, I've shown you that, after the pandemic, I mean, even up to last year where we have data, we see that a large share, much larger, probably 30, 40 times larger than pre-pandemic of visits is done remotely. And the question is, what is it good? What are the impacts of that? And we can sort of, probably it's too early to say, but the debate around this, highlighted some obvious, I mean, the convenience and the fact that it can improve access is sort of obvious, but there were several possible concerns. One is that it might just, making it easy could increase sort of moral hazard or overuse of low value care, both because patients would find it sort of too easy to reach for care when it's unnecessary, and because providers seeing such patients might sort of refer them downstream, start doing unnecessary care like testing and duplicate follow-ups. Another concern, and that of course could increase spending. Another concern is that care quality might be compromised. So this is an open question: how well can we diagnose disease remotely? There are issues around overprescribing. And another issue has to do with the fact that a lot of time these online modes are also on demand, meaning you often see a provider that's available immediately, but it's not your regular providers, raising questions about care continuity and the concern for potential fragmentation. So in this kind of short talk, I'm going to discuss two papers that evaluate different impacts of telemedicine. Sorry, AI is from a different talk. David is going to be talking about AI and and one of these papers is just about increased access to synchronic audio and video visits, and the other is about device assistance in telemedicine. And in both cases, we're going to be evaluating the impacts of this expanded availability on use, cost, and quality. And in any remaining time we have, I'm happy to speculate about the future and discuss some open questions. So the data for both papers come from Israel, 2019 to 2021. And this is from the largest of 4 Israeli integrated insurance funds that by law provide a predefined set of healthcare services universally in a tax-funded way. So everyone is covered. Clalit covers half of the population. And one good feature about this landscape is that there is extremely low churn. So we basically see people sort of in a very stable population across all age groups. And we have fairly granular and complete data, including some EHR data in addition to what you might think is similar to Medicare claims data, administrative claims data for everyone. And it's worth noting that in this context, physicians are salaried, eliminating some sort of direct incentives tied to the mode of care. And I'll go back to this point when I conclude. So the first paper is about the impact of increased access to telemedicine. It's actually just published in the Journal of European Economic Association, and this is joint work with Liran Einav. It was at Stanford and NBR, and with Joe Rashba, my student at Tel Aviv, and Ran Baliser, our colleague at Clalit Health Services. And this is just using the opportunity we have in the data that in the beginning of the COVID pandemic, we saw a large surge in Israel, very similar to what I showed you in the US and in other countries. So we started with relatively low levels of telemedicine. So video was really non-existent, and what you see here is the baseline is some phone calls like follow-up, but you could not initiate calls with the physicians remotely. And then during lockdown, we see this large increase. But what is unique about Israel is because we had a relatively successful initial suppression of COVID, we locked up very tightly and very early. We had a couple of months where we actually thought were a bit like New Zealand, and we had this reopening post-lockdown period where everything was open. We had very low levels of COVID, and we're exploiting this as an emulation of sort of the post-pandemic era. So in terms of how we are using this variation in telemedicine rates, one obvious thing to note is that what's challenging here from an identification perspective is that there's a huge selection into the mode of care. You can't just compare telemedicine visits with regular visits because, as you can see here, just the odds ratio of like different complaints, it's all primary care, synchronous video or audio, but mental health complaints are much more likely to be addressed remotely, and patients with injuries or skin conditions are much more likely to appear in person. So to handle this issue, what we're doing is we're exploiting the heterogeneity that we observe across PCPs in telemedicine adoption during the first wave of COVID. So the way we do it, you can see here on the left, this is just a histogram of the raw telemedicine use rates among physicians. We have about 4,000 physicians, and about 10% of them really just set it out. Obviously, you could sit in the clinic. It's an essential service, so you didn't have to. Everyone was encouraged to move to use telemedicine, but some just chose not to, and some did varying amounts of telemedicine. But obviously, almost no one did just telemedicine because primary care requires some physical interaction with patients. So what we're doing is we're using this, but of course we might be worried that use of telemedicine might be related to COVID trends or things like that, geographic differences in socioeconomic status or in patient inclination to use telemedicine. So what we're doing, we're residualizing it in the first stage to get sort of the physician fixed effects out of after we account for a very large set of observables, including very tight kind of weak controls and sub-district controls for location and everything about the visit we're using for this residualization, like the condition address and so forth. And what it leaves us is with this kind of residuals, which we split at the median, can do it different ways, it doesn't matter. And we kind of define telemedicine nexus based on whether your physician from 2019 has sort of shifted more or less of their care online during COVID. And then we observe that indeed patients of these physicians that shifted more care online, which we call high adopters, have about 30% telemedicine use post-lockdown during the reopening phase, and those with low adopters have only about 8. So this is basically the design. And what we're going to do with this is then based on this classification, which is a proxy. Again, your physician adoption of telemedicine is a proxy for your availability of telemedicine. We're now just going to regress outcomes in a simple diff in diff, comparing post to pre-lockdown outcomes for patients of high versus low adopting physicians. And then again, we're going to account for physician fixed effects because it's possible that low and high adopting physicians are somehow different. And then very granular time, location, and visit controls. Just to note, I think I mentioned it, is that the affiliation is measured at the baseline, accommodating any endogenous switching. What's really great here is that we're going to observe outcomes not just with the physician or during the visit, but really across the spectrum of modes and providers. And that's really what, from sort of a policy perspective, we're interested in. What happens when you provide access to telemedicine to the entire sort of care utilization across the spectrum. The measurement framework is going to be a primary care episode, starting with the visit with no prior encounters except for drugs in 14 days. And we're going to measure things at the visit itself, things like the ordering of tests or referrals in 7 days, follow up with any physician, not just the one doing the initial visit, and the typical episodic kind of measurement of cost and use. And we're stopping at 30 days. It's a convention, but we also can't go much further because after this initial suppression of COVID, things got kind of worse, and then we don't have so much of a clean follow-up period without COVID. Okay, so let me jump into the results, and I'm happy to sort of take questions. I basically going to show you results sort of from zooming in. So starting from just the broad question of what's the overall impact of telemedicine access on overall care use and cost. Here we're comparing everyone, people with or without visits, because the question is, do people start episodes at all? And the baseline period for comparison is 2019, the same sort of 2-month period, May and June, like the post first lockdown, just in the baseline year. And I'm going to show you everything in sort of normalized to the base rate, but just sort of to kind of understand what we're looking at. So any primary care episodes, for example, 18% of the population had any primary care episodes starting in this kind of period. We are seeing in a diff coefficient a 0.6 percentage point increase. So this is dividing one by the area, the 3.5% increase in the use of primary care episodes. So this number is potentially lower than some might fear. So we see increased access to telemedicine is associated with a bit more primary care use, but not by much. When you look at any healthcare utilization across sort of hospitalization, outpatient facilities, and so forth, there's a very little effect. And if anything, it's a bit noisy, but cost is reduced. And we're going to reconcile this increase in use of primary care and reduction in cost by the fact that episode intensity seems to be going a little bit to a little bit decreased. So now moving to the next set of results, now looking at the initial visit outcome. Again, we're putting here in parentheses the 2019 baseline, which now is the entire year of 2019 and early 2020. And we're comparing this, again, in a different sense to just what happens after the lockdown. By the way, I should have said it, but we're in all these measurements, we never measure things during the lockdown itself because it was a very extreme public health emergency period with very limited sort of preventive care or other things going on, for example. So we're not including these. It's all a comparison of post versus pre. So in the pre-period, in 2019, about 57% of Clalit patients coming into a primary care physician office got a prescription, and there's a 5% reduction in this among patients with high telemedicine use or access relative to low telemedicine access. And you can see across the sort of outcomes we observed that we don't see an increase in intensity. If anything, we see a decrease in the intensity of these sort of initial visits. And then looking at 7-day follow-up, we see sort of a reverse pattern where patients with high access to telemedicine are more likely to follow up with a provider, about 8% more likely relative to the baseline of 30% having any follow-up within a week. And what is noteworthy is that most of these follow-ups are with the same physician doing the index visit. And it's in most cases, it is the main primary care provider of these patients. So these relations are fairly established. So in this case, where we provide availability through this kind of, the regular physicians, we don't actually see much evidence for fragmentation, which I mentioned, although this, of course, may depend on sort of the context. Another thing we observe is that these follow-ups are more likely to happen remotely, which again speaks to this possibility, speculating a bit here, that it's easier now for physicians to split a visit that used to be sort of, full of these contingent plans. If you feel worse, can take these antibiotics and prescribe now to let's just follow up in a few days over the phone or something like that. But it could also mean that physicians are less certain about the diagnosis. So this could mean different things, but we do observe this increase in follow-up. And I'm going to talk about quality in a bit. Going to the episodic 30-day measurement, we can see that overall, the cost of all healthcare services used in current prices reduced by 5%. Again, we see very little evidence, and utilization measures are a little bit less noisy, obviously. And you can see that except for slightly more primary care, perhaps a little bit less imaging and labs, we don't see much of a change in utilization, and this is reflected in the fact that we don't see much change in cost, which is probably a good thing, because one of the worry, as I mentioned, was that telemedicine access would result in increased use of unnecessary care that would increase costs. So I mentioned the question of quality, and to move on that, it's very hard to look at the entire spectrum of conditions in primary care. So we decided to focus on 3 specific medical conditions: urinary tract infections, heart attacks, and bone fractures. And we chose these conditions because they're common. They're reasonably unrelated to COVID. So sore throat, for example, was excluded for the reason that it is very sort of potentially confused with COVID, and that was sort of in the COVID era. And what's really important is that likely allow us to observe false negatives, in the sense that if, for example, UTI is left untreated, it's very likely that the patient would be uncomfortable and show up some other place in the system within a couple of weeks, and then we could observe this diagnosis reversal if they're then correctly diagnosed with UTI. So what we did for each of these conditions, because the diagnosis itself is, of course, an endogenous object here, we're trying to understand whether physicians correctly or similarly diagnose over remote modes. What we did is basically we constructed the set of all conditions that include the target condition, for example, UTI, and conditions with similar symptoms. And then we try to see 2 things: whether the rate of diagnosis of the target condition of the all similar conditions has changed in the same diff in diff sense, like I looked at utilization before, and whether it changed in the index visit, and whether it changed within 30 days, addressing the question of diagnosis reversals. And for the interest of time, I'm not going to show you sort of the data here. It's all in the paper. You could look it up. But we find no evidence for higher diagnosis rates or any diagnosis reversal. So there is a little bit of amount of diagnosis reversal in the background, defined as the target condition being diagnosed within 30 days, but not in the initial visit. But there's no change in this rate with telemedicine exposure. So we take this as evidence that, at least in this kind of admittedly more narrow scope where we could look, we saw no evidence for adverse effects on diagnostic quality. So this was sort of looking at the impact of its broad increase in the availability of telemedicine through video and audio. And this sort of raised the question of What about, these other sort of conditions that are hard to diagnose remotely? And that has led us to this kind of second project, which looked at the adoption and utilization of device-assisted telemedicine. It's with the same co-authors and with two additional doctors from Clalit that are pediatric emergency doctors. And this is out in the Journal of Health Economics. And in this project, we look at this adoption of a device. You can see here the pictures that is basically assisting patients in the diagnosis of simple conditions because it has the ability to take pictures of the ear or the throat and listen to the lungs and heart and things like that. And I mean, this is just one device that we're going to talk about, but it's part of, I think, a broader trend that we saw in 2021 post-COVID, a huge increase in the investments in digital health devices. This idea that we can sort of digitize a lot of the sensing, led to an increase in investment in things like remote patient monitoring. And we know now many payers around the world start paying for these things. So this is sort of trying to get a glimpse into how device assistance can help. Here in the specific context of extending the range of conditions that are treatable remotely. As you can see from this ad here, this device in Israel was advertised. It wasn't given to anyone. You voluntarily could purchase it. It was advertised to patients mainly for pediatric use, and indeed the median patient age is 6 years old. So this is, as I mentioned, capable of recording different measurements that are presumably helpful in extending the range of conditions that are then diagnosable or treatable in a video or audio setting. And it's basically mainly used for things like ear infections, throat infections, or eye conditions, as I mentioned, among adopters. Now, here the empirical strategy has to deal with the challenge that device adoption is voluntary. So we are worried here that if we just compare device owners to those without the device, we just may compare people who are sicker and therefore adopt the device. So what we did here is we basically matched very tightly on several characteristics, but two ones I want to highlight is the fact that we match device adopters, defined here as those who use the device at least once. We have 30,000 such patients, with non-adopters who use the exact same primary care virtual care clinic where the device is being used. So we basically look at two people who at a certain week have some sort of episode that brings them to a clinic, one that uses the device and one that does not. And then we actually exclude this initial visit and look at what happens a year later. And we also, because of the concerns for endogeneity of adoption, match very tightly on age, gender, SES, and all the past utilization trends. So for example, 3 months before, we have all these dummies for 3 months before specialist visits or 2 months before hospital visits. So we tightly match the pre-use, pre-adoption trends with the comparison group. And the reason we could do that is that we have only 30,000 adoptions, but millions of non-adopters to pick from. So we have this sort of flexibility in choosing good matches. And so the way it looks like is we get this kind of event study. Again, the pre-trends here are very tightly matched by design. And in week 0, both the adopters and non-adopters have an episode by design. So all of them have at least one visit in week 0. And what we're really interested in is what happens in the 52 years after. And you can see here, looking at just the primary care visits, that there is a persistent increase of about 2 visits per 100 patients per week in the use of primary care among those device adopters relative to non-adopters, which is pretty persistent over time. So it does lead to more care. If you think about quantities, it's a little bit less than 1 visit per year. These are pediatric patients with a quite high baseline of about 7 visits per year. Now we're breaking it down to different modes in primary care. Again, with the same metric, just broken down, we could see that, to our surprise, I should say, it didn't shift people from the in-person visits to remote. It just shifted people from phone and video visits, sort of more traditional telehealth, to this more teched up video and device visits. And of course, added a little bit more because we saw the overall is net increase in the number of visits. So far, I mean, this is about a 10% increase, and it might sort of seem like it's basically just increasing the use of care remotely. But we extend this to looking at the rates of use of other services. And again, the framework here is rates of use over the year following the initial adoption. And we can see again, I should say to our surprise, that the increase in primary care is associated with actually a decrease, non-negligible decrease in the use of more intensive settings, care in more intensive settings like urgent care centers and ERs and hospitals. It does, though, also involve more antibiotics use. And when we further break down things by, and that also is associated with like a reduced cost on these other settings. When we break it down by adults and pediatric patients, and so the median adult patient here is 32 years old, so this was mainly adopted by parents of young kids. We see that a lot of the effects are actually a lot of these reductions in more intensive care use actually occur among these young parents or young patients, and not among the pediatric patients for which the effect is somewhat smaller. So somewhat surprising heterogeneity, and I think this is sort of there's a general lesson here that, you know, these new technologies might have surprisingly sort of heterogeneous effects, and we should sort of keep this in mind. So to summarize, before I move to sort of some broader points, these two papers looking at increased access to telemedicine and device-assisted telemedicine, again, using variation in physician adoption in the first place, in the first paper, and using voluntary adoption with tight matching in the second, increased primary care use by between 4 and 10%, and increased follow-up rates, but also maintain or reduce non-primary care use and total costs. So I think the sort of effects are first not very large and sort of hopeful in sign. And we did not see any sort of compromise in diagnostic accuracy where you can see, but we did see this increase in antibiotics, which again, it's a little bit hard to interpret given that there's a reduction in care utilization in more intensive settings, but it's kind of, you know, calling for sort of monitoring and a potential point for concern. So overall results suggest that I think telemedicine, and this is perhaps sort of some people's prior. I mean, we all tried it, or many of us tried it, and you know, it may be not that dissimilar from talking to the doctor in a clinic for some cases, right? We're talking about 15, 20% average use out of all cases. And some of the questions of, you know, going forward are very similar to the debates about work from home, right? I mean, no one thought that it's possible to work from home before the pandemic, and then everyone started talking about working from home forever, and then we had this kind of convergence into this new equilibrium where work from home is no longer this negligible phenomena, but it's something that is much more widespread. And I think these preliminary results, which obviously sort of call for more work, suggest that, you know, some use of remote care is very reasonable as a substitute for in-person. And of course, we didn't factor in the convenience and all this kind of scheduling ease and things like that that come with it, and add to the kind of pro side. But of course, many questions remain open. So looking at how we should pay for telemedicine, I'm kind of taking here the codes from the American Medical Association. You can see in a fee-for-service framework, you have to start granularly sort of divide space kind of arbitrarily into kind of online visits 11 minutes to 20 minutes, and it's not obvious that this sort of induces the right sort of level of use. So, I mean, if you look across different countries, there are many models now circulating. So Israel, UK, Sweden use sort of more low-powered incentive modes. Some countries like Germany or Australia have some caps. In the US sort of explores how to do it in a fee-for-service, and this might affect outcomes. And I was pleased to see our next speaker's Professor Cutler's sort of paper coming and kind of doing an analysis that very much speaks to the impacts in the US. And it was, I should say to my surprise, not very different than what we see here in Israel. So this is just came out in the Health Affairs, and so I think the debate is still open of how to pay for telemedicine in order to induce the right innovation and induce incentives to save time and so forth. Then, like, just very briefly skimming over some other open questions. How can we get patients to the best mode is a really open question. Do we let them choose? Do we have some algorithm sort of route them, nurses? How to account for potential heterogeneity, which I mentioned. So think about remote patient monitoring. You know, Ariel Dora-Stern is working on these things, like how do we make sure we're not over-adopting some of these new technologies and overpaying for them? What will happen to provider-patient relationships with the shift online? disrupt the continuity of care relationship. We didn't see much evidence for this in Israel, but of course this might vary with the environment. And if you start offering direct-to-consumer telehealth, it might sort of do more harm. And how should we assure equitable access? And just one last data point. When we looked in Israel, we saw that even for free phone-based telemedicine, we see these kind of SES gradients. So it's not just insurance coverage and broadband. There might be other things like education or cultural differences that might sort of hamper adoption among some groups. And the question is, going forward, how do we guarantee that everyone has equitable access and overcome barriers for adoption? Thank you very much. I'm happy to take questions and, of course, continue this offline post this meeting.
Thank you, Dan. Are there any questions from the other people attending the seminar? No? Lucy?
Yeah, I have a question regarding the introduction of the device. Are there particular incentive for people to adopt it, or it's just like, hey, there's a new device-based diagnosis or utilization?
So I must say I was surprised by the results, because we initially came into it thinking that this device is the classic selection based on sort of cherry picking based on sort of attracting healthy patients to just get it for the kids, because I mean this is like really generally catered, like targeting like generally healthy kids that you can do your upper respiratory infection sort of visit in the comfort of your home. And it was basically mainly advertised as a convenience device, and it was subsidized. It was $50. So this is basically the target audience.
Thank you. I think Adriana is next one.
Hello, thank you, Dan, for a very interesting double presentation. So we get two for the price of one, and now we're going to get another one as well. I had a question about the choice of your diagnostic kind of diagnosis for this to assess the diagnostic quality of telemedicine. None of them strikes me particularly well suited to telemedicine. Heart attack, bone fractures, usually if you have them, you go to an ENR. So would you have not selected others?
Yeah, we picked these, as I mentioned, for being common in both settings. So, I mean, this is something I learned even before we did it from Ziad Obermeyer. Not all heart attacks are like someone collapsing on the sidewalk. And actually, we see quite a lot of heart attacks in our data that initially appear in a telemedicine setting and then are being sort of obviously referred and treated remotely in person. So it's not the right mode to treat a heart attack, but it turns out that actually quite a lot of heart attacks, they start with chest pain and other like moderate symptoms. That could be other things. That's the poster child of misdiagnosis, confusing a heart attack for heartburn. And we do see them. And it's also true for bone fracture. So because in this period, many people use it, we have overall 10 million visits. It's actually a non-negligible number in the thousands and tens of thousands of these people who have them in both modes. And we picked them because of this. We needed conditions that were likely to observe false negatives. So this was the choice. Admittedly, this reduced our power and limits, what we can say for this. And of course, for other conditions, we say nothing. But yeah, thank you. I think there's lots of work to be done there on like understanding diagnosis in different modes. We're certainly not saying the last word.
I guess it also depends on the type of healthcare system that you are within. So, for example, if somebody might have experienced symptoms of potential heart attack, perhaps in the UK where I'm based, we would call 111. Or we could go online. You have an NHS online 111 system where you can self-triage yourself, and then they tell you where to go next.
Yes.
So, but it's very interesting. Thank you very much for your answers.
Thank you. Thank you.
Thank you. Divya, please. Your microphone, you muted.
Sorry.
Yeah.
Sorry. Thanks very much. That was absolutely fascinating. I had a question about what you classified as the adopters that were the early adopters. And I just wanted you to talk a bit about if you thought there were certain types of characteristics that helped you kind of, I guess, section the data like that, or kind of helped you guide and identify, I guess in this case, GPs that seem to be maybe more digital savvy than others?
Yes. So just reminding everyone of the definition, we defined high telemedicine adopters as those GPs that after residualizing, we use the set of cases during the early period of the lockdown, like the first lockdown. So this is March and April. And so those who looking at individual visits after residualizing them by patient characteristic, visit characteristics like the condition being treated and time and location, those physicians that, statistically it's the fixed effect on the physician that even controlling for all the things, their overall rate of telemedicine is above median, we defined as high adopters. In terms of what their characteristics are, they tend to be physicians of slightly older patient panels. This was COVID, so that's obvious. Slightly more female, slightly more in high SES areas. But of course, we sort of adjust for all these things. So, I mean, we're really, the sort of natural experiment here is two physicians in the same town, that just varied in their decision to sort of adopt telemedicine. And we'd use physicians sort of fixed effect. So all the comparison is sort of assuming parallel trends and not sort of identical sort of pre-trends. Thanks a lot.
Thank you.
Rishub, please. Sorry, I hope I said your name correctly.
That's totally fine. Hi, everyone.
you.
Rishab Kilar from the OECD. I had, perhaps I might have missed this, but do you know how telemedicine appointments are paid in Israel or reimbursed either by video or telephone?
Yes.
And I'm wondering maybe your opinions or maybe any evidence you have on that split of the primary care increase, whether that was maybe more patient-driven or perhaps maybe provider-driven based on the financing? Thanks.
So the finances, I mentioned it briefly, and thanks for raising it because this is super important. The finances are such that in Israel, physicians in Clalit are salaried, employed by Clalit and salaried globally, based on the size of the patient panel. So they're targeting patient engagement sort of over sort of long periods of time. So it looks a little bit like ACO virtual attribution, and they're not being paid more or less for individual visits. So it's de facto payment parity between the modes, I suspect that it might explain why we see this kind of results that are small, but it's up to people in other countries to actually examine the effects and kind of see how much it depends on the payment system. And I think this is an open question. We can't answer it like using just this data, but I think it's an advantage to kind of understand how physicians make these decisions when they actually don't there's no financial incentive one way or another, and this is what we're seeing here. Thank you.
Okay, so this is the time limit. Let's move on to the second presentation. David is going to talk about AI and healthcare now.
I will do my best to do so. So thank you very much for inviting me. And this is just a wonderful opportunity for me. Let me first make sure I can show you the things I want to show you. And can everyone see this okay? Awesome. So actually, Dan did a wonderful intro, both to specific papers and also to the general issue. So some of the things I'm going to talk about are going to follow from what Dan said. I'm not going to present specific papers because I think the field is so new that I'm not sure there's a way to summarize them nicely. And I don't just want to just sort of pick here and there. But so what I'll do is I'll try and lay out some general themes, and then I'll show you how some of the papers fit into that. Let me first just start off by saying congratulations to the Digital Technology Interest Group, because I think this is really just a wonderful thing to do. I'll start off first with a caveat, which is I don't think of myself particularly as a text expert. So I don't sort of design AI programs or implement them or anything. So I thought basically that where my comparative advantage was to give pithy sayings that sound great but are mostly meaningless. And that way you would think I was really bright, even if I didn't actually say anything. So here are a couple of pithy sayings. It's easier to swim downstream than to swim upstream. So I could tell you that. And of course, the one we always use when we're stuck at the airport with someone who finds out we're an economist, the inversion of the mid-length treasury yield curve combined with the inventory overhang means that GDI is in for a rocky Q2. So in case you're ever stuck somewhere, you can just use those. Let me, so I want to start by, one of those I'll actually show you has a little bit of relevance to today's topic. But let me just start off by defining some terms. So what do I mean by AI in healthcare? And so I've written about this a little bit. So let me just sort of give you some of my thoughts. I'm going to think of AI as having two components to it. The first is machine learning. That is a computational technique to learn from existing data rather than just operate on a fixed set of rules. So an example is who's likely to suffer a clinical setback after hospitalization would be a problem well suited for AI. And then the second is natural language processing, which is a computer's ability to understand human language and to transform unstructured data into structured data. So an example of that would be analyzing clinical notes, a clinician's notes of a visit to infer a patient's risk profile, something like that. So those are the two things that I want to think about in terms of AI. So then the question is, what do we want AI to do? So what I want to do is say, what do we want AI to do, and then whether it's likely to, or what considerations would lead one to think about that. So sort of around the world, I think the biggest need is to improve the sort of triple aim, the sort of IHI triple aim, or sometimes people think about it as the quadruple aim: better health, better care experience, and lower cost. That is particularly true in the US, as everyone knows, but I think it's true in every country as well, that sort of costs are an issue and the quality of care is an issue, and certainly population health is an issue. Just to show you, obviously, how big this is in the US context. In fact, that's sort of where I want to start off and then generalize from there. You know, this sort of chart from the OECD shows you that the US used to be a little bit of an outlier, and then it's just become increasingly an outlier. Being an outlier on the right of this picture means that you're spending more than other countries. Being an outlier on the bottom of this picture means that life expectancy is lower than in other countries. And so the US does both of those. So the key goal for the US is to move up and to the left. But as I was saying, I think that's sort of the key goal for a lot of countries. So even countries down here will want to move up and to the left, and then even ones on the upper side will want to do that. Note, here's Israel up here. So this is what Dan was telling you about in terms of Israel. So Israel is already an extremely well-performing country. And so I don't know, like, to what extent that what he was showing was actually similar to the US, but one could imagine that the impact of telemedicine would be different in a country that was either spending more or spending less in terms of what the cost of the spending was, or that had worse health outcomes than Israel does. Israel has enormously good health outcomes. Okay, so how can we then think about AI here? And immediately we sort of jump to the clinical component, like what is AI going to do when it comes to a care visit between patients and doctors, and what's it going to do to radiologists, and so on and so forth. And the first thing I want to think about is actually starting broader from that. So if you think about the sources of waste in the US, there are two of them, I think, that are particularly important and amenable to AI. So the first one here is clinical waste. So that's spending that could be reduced either by not doing stuff which is not helpful to the patient's course of progress, or even a little bit helpful but nowhere near the cost. So things like doing very intensive efforts at the end of life for which there's no clinical basis to think it would be valuable. The second one for which AI would be particularly valuable is administrative complexity. The US has among the most administratively complicated systems of anywhere in the world. In most countries, what services are covered is set by the government, and the payment rates are set by the government, and so on. And in the US, all of that is decentralized, and so that brings with it huge amounts of billing messes and issues with administrative costs there, and I'll just go into slight detail in just a second. There are other areas in which I think AI could be helpful, and I know a little bit less about them. Excessive prices. In the US, obviously the pharmaceuticals are the key issue here, but we also have, laboratory imaging prices vary a lot across different providers. Same thing is true with physicians providing very similar services. And then, of course, we have a fair amount, nobody knows the exact number, but a fair amount of fraud and abuse. AI could actually certainly help with the fraud and abuse end, because it would be fairly good at spotting patterns that look different from previous patterns. So, for example, one way one spots fraud and abuse is by saying, where am I seeing a lot of spending today that I didn't see last month? And that would be that's at least some indication of potential fraud. It may also be an indication of things like the spread of a new infectious disease and so on. I want to concentrate primarily on the first two, which are the clinical waste and the administrative complexity. And I just want to note that actually probably the first area in which AI is likely to be particularly important is the administrative complexity. So if you think about in the context of like a healthcare system, what is it that's happening? Well, you have a lot of billing services. And depending on how you do it, the billing can be very easy, as in like you don't have to submit a bill, or just in the norm, if you saw the patient, you just send something in saying you saw the patient, to what happens in the US and in some other countries, which is a very elaborate billing system where you write down exactly what all the conditions of the patient were going in, what is it that you diagnosed, what are all the services that you provided, any other clinical notes, and so on. And so those types, and that's a lot more costly. So in the US, there are literally like entire buildings of people devoted to just billing. So, you'll have a sort of big office building, and in there are people who literally what they do is they take information from the medical record, and then they enter it into a separate billing system, and then off goes the billing information. Well, once you take information from one system, put it in another system, and then send it in, what you should automatically, where your mind should jump is, gosh, isn't that what AI could be good for? Because AI can literally take that information from one system and transport it into another system. And so I actually think that among the biggest areas of AI to have an impact will be on the administrative parts. And I say this, I think of this as what's going to be a very, very interesting research question, in the same way that 10 to 15 years ago, there was a big move in the US, as there was in much of at least the developed world, to implement electronic medical records. And one of the questions that health economists looked at a fair amount was, how do electronic medical records influence care processes, and how do they influence the administrative costs and consequences of providing medical care? And I think that that's going to be entirely relevant for the AI revolution as well. And so I'd really love to see both sort of studies from obviously the US, because as a US researcher, I care a lot about the US, but just comparative studies and things like that to get a sense about where are we doing it, where are we handling things well, and where are we not handling things quite so well. Some of it's going to require coordination, like for example, on the billing situation, the provider is billing to the payer, sending the bill to the payer, so they both have to align on some standards in order for that to happen. Some of it can just be within a single organization and so on. Okay, but so that's the first part. And the key thing that I want to think about there, if you will, is substitution. That is what I'm looking for there, is substitution of machines for people. Machines are nowadays cheaper than people, so substituting machines for people is going to be an overall cost savings. I want to turn to the clinical end, which I think is where most people's brain goes. And here I think less about substitution than I do think about complementarity. And I think Dan's example is really just perfect here. His example of the pediatric sort of thing. I think for both technical, legal, and economic reasons, AI is likely to complement clinicians rather than substitute for them. And this, again, is exactly what Dan was finding, which is you have the new thing which can, take a picture of the ears, or take a picture of the throat, or listen to the sound. And what does it do? It doesn't substitute for a doctor's visit. It complements a doctor's visit. Maybe it's now a better doctor visit because you have what the thing says, and you can do something from home that you had to use to bring the child in for. Maybe it's a less good visit because actually the thing isn't so good, and if the doctor saw the child and was more familiar with the child, it would be better. And Dan was obviously looking at both of those sorts of angles. I think this complementarity issue is actually is a very big one here. And and there are a lot of economic issues that come along with that. So for example, there have been just a couple of papers on, for example, how do you want to combine, let's say you're using AI to read an X-ray, and then you're giving that, or CT or something, and then you're giving that to a radiologist. What kind of information output do you want the CT to give? So do you want the CT to say, I'm 92% certain that this is lung cancer? Or do you want the CT to say, well, I'm pretty certain of what this is, or I'm not certain of what this one is? And then have the doctor take over from there. So actually, the right way to go about combining those is a kind of first order, I think, economic question, because, all the things that you hear about, like, for example, with electronic medical records, oh yeah, it just gives me pop-ups all the time, just a bazillion pop-ups. So what do? I just keep clicking, okay, and I never pay attention to them. So you could wind up in the same situation where you just go with what the AI says and you never pay attention to anything specific. But we know that the AI is not perfect, so you don't want to do that. The reason why you want to combine these is because you think there's some particular knowledge that the doctor brings and some particular knowledge that the AI brings that may be different from the doc. So I think thinking about that combination of stuff is a really big economic issue. And as I say, there are a couple of papers on it, but not an enormous amount. A second clinical version where I think there's a lot of promise, and here it's both in rich countries and in lower income countries, is less expensive diagnosis. So I've shown you a couple things here. The first one up on the top is how do you diagnose Alzheimer's disease? And the current standard for diagnosing Alzheimer's disease is a PET scanner, which is extremely expensive. They're not, even in a rich country like the US or rich Western European countries, there are not that many of them. It's difficult to do, these are not, for patients who are having dementia, it's not an easy thing to do, and so on. The other thing you can do is take cerebral spinal fluid and look at the cerebral spinal fluid for various kinds of proteins and so on, and try and guess from that. But that's, again, very difficult to do and so on. And what would be far, far better is just to take like an MRI image, which is much easier to obtain, and then use that to predict, well, whether the person has Alzheimer's disease. You might both want to predict Alzheimer's because there may be a drug for Alzheimer's you might want to do, or you may just want to say, what's the best prediction of whether this person is going to have cognitive difficulty 5 years from now, in which case should their children and family and friends and loved ones think about, setting up some alternative care arrangements for them in advance or things like that. So that's an example where if you can do things less expensively, both by money and by effort and time, would be extremely valuable. The other example I have here down at the bottom is in many low-income countries, for example, diagnosing something like, is this person having cardiovascular disease? Or is this person have diabetic retinopathy? And here again, for many things, you can use a cell phone and some smart code, just like Dan had the cell phone and a couple of little gadgets and a smart code. So use the cell phone and a couple of little gadgets and some computer code, and that can substitute for a human being. In this case, because the human beings are just overworked, and there just aren't enough trained human beings to go ahead and do this. And so I would be really, really excited to see trials that look at, when can you do this? And I've shown you here a picture of I can't remember if this is where this is. I think it's in rural India. It is in rural India. I can't remember where in rural India it is. But this is equally applicable to, I think, for example, how should you care for people in the West Bank? Or how should you care for people in Alaska, where we don't have very many physicians, or just a whole host of other areas? And so this kind of less expensive diagnosis is one where we could use a lot of work. And this is then related to one of my pithy sayings, which is it's easier to swim downstream than to swim upstream. What do I mean by that? The money flow is going to be really, really important here. And so whether clinicians will use AI is going to depend a lot on what are they reimbursed and what is that relative to the cost. One of the things that there's no standardization on at the moment, which I think is going to be very difficult, is how AI is paid for. So let's say you're a clinician and you've got, an AI thing to do this or an AI thing to do this. How is that AI thing going to be paid for? My guess is that just like a lot of software, it'll be on a kind of monthly subscription basis. That is, I'll pay $20 a month and then I'll have access to the AI technology, and, the AI technology will always update itself. Or maybe I'll pay an annual fee and I'll have access to the AI technology. In which case, then the marginal cost of using it will be zero. So you don't have to reimburse much at the margin. If you do reimburse at the margin, you're going to get the doc doing it on everybody, which may be good depending on the thing, but may not be good. On the other hand, it may be that they charge per use. Like, for example, this machine, which is designed to look at the eye and to test whether there's some problem with the retina or other diabetic issues. On this particular thing, I think they actually charge by the time you use the machine. Every time you use the machine, they charge you, and then the image goes off to the company, and then the company sort of shows you the image and then also gives you its interpretation of it. In which case, how you go about paying for that is really going to influence a lot how it's used. And if there's a marginal cost for each user and you're not paid for that marginal cost, then it's going to be a big deal. So it depends a lot on whether there's a kind of purchase model or a subscription model in terms of whether you want the prices to vary with each use or not. My general preference, based on what we know from a number of different studies, is that if there's a specific technology involved, like, for example, a big machine that takes a picture of the eye and then interprets it, that I would prefer to bundle the AI with the technology. So just say, if I'm paying you to use the machine, I'm going to just pay you, it's the machine plus the AI is what you're going to get. And you're not going to get a separate amount if you use the AI or not use the AI. It's just what you're doing is you're using the machine to do the interpretation. A second rule that I think is try to pay the same way that docs pay. Again, if they're paying on a monthly subscription basis, then I don't need to pay them for every use. And I just want to make sure that I'm giving them enough to afford the monthly subscription basis. And if there's a lot of harm from overuse, for example, from testing and so on, then I've got to be really, really careful about the overpayment. And similarly, I better be very, very careful about these underpayment in that. Okay, so another lesson, and then after this lesson I'll stop, but another lesson is, I think we've sometimes set the goal as being, I want to develop a computer program that can replicate what docs do. So we sometimes see that, like I want to develop a radiology read program that can do just as well as the best docs. And actually what I want to say is that that's not good enough. And there are a lot of biases that docs bring to things that I really don't want to replicate. So the example of this from work that I've done, but there are many other examples, just because I know this one best. This is on how do you tell how bad someone's knee is? So what you're looking at here are pictures of X-ray images of a knee and their various degrees of arthritis. And it's generally well agreed how you'd grade the arthritis and so on. And the pain is associated with the grade of the arthritis and stuff like that. But it turns out that this method of grading knees was developed for 1950s British men. And it actually does much less good at low-income minority patients in the US than it does for British men from the 1950s. So in fact, if you train a sort of neural network, one of those networks that tells you whether your picture is of a dog or a cat, just by looking at it, if you train one of those to predict knee pain, it will predict, it will do a good job. It'll do a very good job. It'll do a better job than just the physician looking at the scale of, than just looking at the X-ray. It'll pick up on features of the knee. It's unclear exactly what it picks up on, but actually, if you then gave it a bunch of images and said, okay, now decide who should get a knee replacement because they've got a lot of pain, it would allocate a lot more knee replacements to low-income and minority patients than does the traditional grading of the knee. And so if you just wanted to replicate what is a very common standard here, an arthritic standard for, a standard for how arthritic is the knee, what you would do is you would wind up perpetuating some biases of physicians. And that's true across the board. Like there are just a bazillion studies about how docs operate with particular biases, the N-digit bias. If your age is 60 and you show up in the emergency department, you're likely to get different care than if your age is 59, because some things you're told to look at after 60. And if your test is, just above the line, you get coded as diabetic. And if you're just below the line, you don't. But the underlying risk is continuous in it. So there are a lot of things for which docs use biases, for which docs are biased, whether explicitly or implicitly. And I don't want machines to replicate that. And it's very, very easy to replicate that by just saying, I want to match the best that's out there, whereas we need to do better than that. Okay, so here's what I want to do. Here's what I want to suggest. One is real focus on doing better, cheaper. Second is one thing I didn't go through, but I just wanted to mention here at the end, which is cheating it can be a big deal. Both the doc can cheat by saying I use this computer program when they didn't even really use it that much, but also the programs themselves have a hallucination problem, and so someone will have to make sure to train the program so that they don't hallucinate things. Third is, I think there are opportunities for substitution, opportunities for complementing existing workers, and we really want to be very careful and think about how to structure those so that we get maximum productivity. And then fourth is sort of, because this is health economists, I felt like I had to end here, which is don't fight the monetary incentives, you will lose. So figure out how to incorporate the monetary incentives into what we want to do, or more accurately, think about how we can design the monetary incentives that are going to work best in an AI world. So let me stop there and just thank you so much for having me, inviting me to be here today.
Thank you so much for the very intriguing talk. There'll be 5 minutes for David's question. I actually have a question to get started with. You mentioned it's very important to still run clinical trials as AI can generate bias, but most of the AI embedded medical devices are still going through the 510K clearance in the US rather than pre-market approval. So how can we reconcile these conflicting motives here?
Yeah, I actually having a little trouble hearing you, but I think you're asking about how we can make sure that it doesn't replicate the biases. I think part of it is we're just going to have to force things to do the clinical testing. So ex post, we're going to have to look and see, who does it pick out? But it can happen in very subtle ways, So the Mullinath and Obermeyer version of it is you're just trying to predict who's going to be a high spender. and you want to intervene to help people who are going to be high spenders spend less. And so the problem is that whites spend more than blacks do. So your program, even if you don't give it race, will find attributes associated with race and then say, look, go send extra visits to those folks because they spend more. And so if you want to prevent spending, you've got to do that. So I think it's going to be not just like making sure that the program itself doesn't have biases built in, but that in practice, it winds up not having biases built into it. And that's going to be difficult because we're actually going to have to look at the outcomes, not just the what the lines of code say they do.
Thank you. Any questions from the audience? Georgia.
Hi. Thank you, David, for your presentation. I think that there are some issues in your presentation common to that of Dan. For example, I was thinking about the broadband coverage. Of course, and the fact that you both get similar results might depend clearly on the fact that some countries have a very poor broadband coverage. So probably it is definitely interesting to consider other countries less I would say industrialized, but it's not industrialized the correct word, or the fact that probably Israel is a very young country compared, for example, to Italy, where people are very old. So the digital divide is an issue. I don't know if you want to comment on that, both of you, of course, even though Dan had already raised the issue in the last slide.
I think it's a very important issue. I think the digital divide is very big. So in the US, we have the issue a lot between urban areas and rural areas where, in Boston, where I am, the internet generally works pretty well. And in parts of rural Oklahoma, where I'm not at the moment, it tends to work less well. But there are also things like, for example, low-income populations have difficulty kind of maintaining a sort of broadband connection. So if you say, if say you have a loved one who's 78 and is, feeling a bit dizzy, they may call their primary care doctor, and their primary care doctor may say, oh, well, I can do a video visit with you. And the person says, well, I don't really know how to do that. And then they say, well, the problem is I don't have any in-person visits today. Today is Tuesday. How about Friday? And the person's like, well, I'm not sure I can wait till Friday. So then it's like, okay, well, why don't you go to the emergency department, which of course you were trying to prevent the whole time. And that could very well happen anywhere. It's not an issue of like, do you have broadband? It's just like that person is not really able to handle that situation. And so I think it's going to be, a big issue. I would love to, again, experiment with things where we say, can we just put even simpler technology in the homes of people who are elderly and infirm and just see, even if it's not as great as the thing that Dan had, where, you sort of listen to the chest and it records the thing or whatever, but just something so that in that circumstance, you can get some information to that person. How well do you do relative to the first best?
Any other questions? We have a question in the chat from Christopher. Christopher, would you like to speak? Or I can read it. How do you reckon we handle monetary incentive for the manufacturer of those technologies to have them available in low resource or resource constrained settings or fragmented health systems?
It's a great question. The model that the world has evolved about pharmaceuticals, particularly vital pharmaceuticals like HIV meds and so on, is that the poorest countries get drugs at cost, and the richer countries will pay more, and the US will pay the most. And we're not going to question that the poorest countries get the drugs for free. It's just going to happen. And we in the rich world will not re-import from Botswana HIV meds. And that's just the deal that we have. And then the biggest problems are, where does Thailand fall compared to in between Botswana and the US in terms of pricing? And I would love to see the same sort of implicit pricing schedule for AI technologies, which is the diabetic retinopathy machine is priced at cost in the lowest income countries. And as income goes up, it gets priced a little bit higher until you're at the rich country price, where I don't like the fact that the US pays more than other really rich countries, but but then you sort of make it up to the rich country price. And we just agree we're not going to re-import from low income countries and things like that. And so I think income-based pricing at the country level would work very, very well. And then my hope is that we can do some of the same things we've done with meds, which is treat AI as what it is, which is a medical technology, which can be extremely effective for people. And just like basic medications that we say are too important not to be able to afford, some forms of AI are likely to be so important that countries should not go without them. I'm not sure we're there yet, but I could imagine us being there soon.
Sure, I think we can move to the time of open floor discussion. So welcome to send your questions to both speakers. Alexandra, please.
Can you hear me? Sorry, can you hear me? Yes, sorry. I'm in the airport, as you can hear, probably with 3 hours late on my flight. So sorry again. A question for David, actually, because since we were talking about prices, I was wondering, for all digital health in general, it's very important also to consider, for example, expert health professionals that can help people to manage the technology. Some days and in some circumstances I'm not able to use this technology. So I was wondering, if I put such a device in my grandma's house, is let's say something to consider whether she can use it or not. So we also think we need to consider the prices, let's say, increase for training ad hoc professionals in order to tackle the digital development and digital health in general evolution, let's say. So how much this will impact on the development of digital health. So thank you again, and sorry for all the mess behind me.
No, thank you. It's a great question. It's a little bit related to something which is there's a movement that you see in some parts of the world for hospital at home, which is if you have someone, not surgery at home, but someone who needs some convalescence or someone who's recovering from a serious event, can you move them home? And some countries do very well with that. The country that I have in mind is Singapore, where they sort of, at least by what I've spoken to people about, they have they put a lot of resources into that. And partly that's making sure someone can go to the house of people regularly and make sure they're doing okay. But also it's the digital monitoring. Like, for example, can you be monitoring someone's both level of pain, but also their blood pressure or whatever else you need to monitor, and then get that to a place where you can look at that centrally. And so I think that that's a similar sort of thing. In the US, we did a little bit of experimenting with hospital at home during COVID, but not particularly that much. And I think, I don't know how much other countries did. My guess is there's opportunities to do so because, like, for example, in the US, we're having an incredibly hard time finding like people to work in nursing facilities and home health facilities and stuff like that. So that's going to push for some of that. And my hope is that we can take advantage of some of that and learn how to do more caring for people. And undoubtedly, as you said, it's not going to be the same for all people. Some people will be fine with their iPhone and, iPad and so on. And some people are not going to know how to turn the thing on.
I can also speak to this briefly. I think the idea that, I think what we sometimes tend to forget is how scarce medical expertise is globally. So I think all these new technologies that complement human skills, I mean, there's a lot of discussion about substitution, which I think is completely misguided, given that we're basically missing a lot of expertise. Before we start replacing, I think complementing and extending the reach is a much more likely and better program. And both in terms of telemedicine, if you think about the developing world, this idea that, a nurse equipped with a portal could assist patients reach much higher levels of skill that are situated remotely. And in the context of AI, this idea that you can upskill medical professionals by providing them, with this intelligence that might not do well on its own, but if they have, I mean, this is an open question. I don't know that necessarily ready for market, but I think looking forward, this idea of taking medical professionals that basically could use the device, this sort of AI technology to upskill themselves is a good sort of outcome, would be a good outcome in that regard.
Thank you so much for your answers. Thank you.
Adriana, you're next.
Yeah, I just wanted to come in on what David said about the hospital at home. It was something that was done in the English NHS. It was called here the virtual ward, and I think it's one of the elements of the policies introduced during COVID-19 that NHS England has retained even after the possible going forward. And that is kind of pushing, and you would like that, I think, David, the efficiency of the system and the increased productivity of the system, because obviously it is in the papers and it's not a feature of the English NHS that too many millions of people's waiting for surgery, and a way of, you know, cutting down that huge list is by trying to get patients out a bit earlier from the hospital if they are healthy to be discharged, but to continue monitoring them through this, you know, medical devices remotely. So I think, at least in England, I don't know what the impact is. I've not done any studies personally, or I've not read any studies recently on the assessment of this, how effective it is, cost effective, and the impact on quality. But these are all the open questions as you put there in your three. The triple aim, you know, the patient experience, you know, there will be studies and there should be studies everywhere in the world, and perhaps cross-sectional and cross-country studies that look at exactly the same type of intervention, the type of impacts they have, to be able to understand and elicit those that are better suited for certain conditions. And I think that what perhaps data and data sharing will allow us in a global world to kind of share knowledge, best practice that is not just within a country, but it's across countries, because the issues are wherever, everywhere in the world, no matter whether it's publicly paid for or privately paid for, you still have similar kind of issues. On the equity digital divide thing, I'm Italian as well, and I know that the older generation in Italy is potentially less tech savvy than the newer older generation will be. So hopefully when I will become old and retired, will be a bit more able to deal with technology, having had a lifetime of experience. But it is definitely an issue that no matter whether the device will be delivered, you know, free of charge, if you do not know how to even turn it on or use it, that you know, there's nothing much one can do about it. And yes, and that's just to say thank you as one of the covenant of this, you know, very brilliant talk as well, David. I follow you, as you know, and David, I've met David for a productivity project of ours, so I follow him also for other reasons, and it's interesting to know that we're both going in the same direction, assessing the impact of digital health technology on productivity of health systems. So I leave it here for now. Thank you.
Thank you. And I would love to see just what you were talking about. I would love to see studies that looked within country, across countries, comparison studies, just anything that tells us how these things work, what's working well, what's not working well, what you can do differently, better, stuff like that.
We have about 12 minutes, so Divya, and we have a question in the chat after.
Thank you. So thanks very much, David. That was absolutely really interesting. And I just want to come in on 2 points around the AI. I think some of the work that I've done is actually around, you know, whether depending on what type of AI algorithm you're thinking about, there is this question that Adriana raised around kind of these de facto global databases of just this real world data and how countries are handling that, and if they're being proactive in the regulatory side of kind of harnessing that information. And there is a bit of a shift around that. I think coming back to kind of us as being health economists, you know, what can we gain from this? And I think what's really important about informing some of those questions on productivity is just how we think about standards around economic evaluation for AI. And I thought I would just do a plug, because actually we're going to be coming out with a paper around the reporting standards kind of checklist for those of you that are interested in AI, And I think that when it is shared, I'll share it through our website, because we use that checklist looking at recent publications, looking at AI algorithms, and it's variable in terms of the methods used and the quality. So I think your point about comparisons, we need to have some baseline to do the comparisons. And I think that as we go forward, there'll be more studies coming up. But I think we need to have comparisons that are kind of assessed in a way that make a constructed framework around the discussion and to inform the debate. So thanks very much.
If I recall correctly, there was, in the 1990s, there was a panel on cost effectiveness in health and medicine. And that set standards for how you're supposed to do cost effectiveness studies that I think turned out to be very, very influential. And therefore, after that, you really saw a lot of like, look, I need to be doing it this way, and this is the right way to do it, and so on. And then you could even compare across them, because then you could say, gee, look, is this, I can take these 4 studies and try and form a uniform view from them, rather than having to interpret each one completely differently and stuff like that. So I think you're entirely right about what things we want to be sure of, even things like about the costing. We have to be clear about the difference between fixed costs and marginal costs and average costs and so on. And just like all sorts of things that we really, really need as economists, we really need to know.
Cool. Anuj, do you like to ask your question in the chat by yourself, or?
Yeah, I have a little 1-year-old with me, so it's probably not a good idea that I do this purposely. So if you don't mind reading it, that'd be great. Thanks.
Okay, cool. For David, how have you seen AI potentially being used less for specific curative service delivery, but analyzing population data for more targeting and delivery of preventative services? This could be very useful, especially in low and middle income countries, but often the access to quality routine data is a major hurdle.
Yeah, I think that's exactly right. It's like, because you really want to do the preventive stuff, like the example of the sort of EKG testing is one of the things that you really want to do in terms of testing and someone with diabetes and so on. I think folks are still kind of experimenting with it. My sense is a lot of the testing can be somewhat more universal, like particularly if it's just taking a picture and it's looking at the picture to do something, that can be fairly uniform. I think what is likely to be harder is if you have to align the patient in a certain way, or the picture of the eye has to be a certain thing or something like that. You can get some of these have to be more standardized in terms of how you actually obtain the data. But my hope is that we can borrow across a lot of settings to train the models so that they look so that they can do really well in all sorts of settings.
So Dan, would you like to add to that?
Yes, I think what's interesting about digitization in general is that this is something that started with the HR, but now I think catching up, because the more digital interactions are, the more sort of digital data is being collected. That could be sort of pictures or just reported symptoms, which is something this is very dear and rare in medicine. Often we have just summarize of reported symptoms by providers, but now we start to have patient-reported data at much higher granularity. And I believe all these together would give rise to, and then obviously just the HR itself, could give rise to all new opportunities to prevent and detect disease and do public health policy. So just for one example, this is not my work, but our colleagues at Clalit had this, I think it was Nature Medicine paper, where they showed that to diagnose osteoporosis, you could just take the universe of existing imaging that you have in the population data set and train algorithms. Even without a referral, if a patient has a sort of persistent sort of imaging that's just made for other purposes, you could actually detect that they're at high risk of low bone density and call them in. And this is just the general program here, is that you have all these data sitting there, and you can start doing sort of preventing, targeting population health measures, and this is new, and this is facilitated by this kind of digital aspect. Of course, people talk about silo data. You need to have a lot of integration for this to work. But I think we're going in this direction. This is an exciting sort of time for this kind of efforts.
Thank you both. And also just echo one point raised in Anuj's question about low and middle income country. Actually, although we are looking at high income country setting today, there are also a lot of progress and improvement in Asian countries in Oceania. We'll try to include very diverse geographic coverage, both in terms of time and speakers. So next time, potentially we can see some more Asian-based or Oceania-based AI and health. We have two other questions in the chat. Kathleen and Daniela, would you like to ask them yourself?
I could. I just had the thought with it. I thought that was interesting to say, how could we use this for preventive services when you have patchy or spotty data, lack of data? And I was thinking maybe that would be a use for AI would be to sort of fill in those gaps. You know, I mean, I know there's a lot of biostatistical work on data imputation, and maybe this would be a way to, which is tedious, and this would be a way to use AI at a more population base.
I think the machine learning aspect of it is really critical here, actually. And you can use the machine learning to take what you have and to impute what you don't have. And it can often do better than, you know, the simple rules that we would come up with, like, you know, run a regression and then just do a prediction from that. So I think there's a lot of stuff we can do there. And just in general, learning about things at the area level where we don't have a lot of information, but borrowing from nearby areas is something where I think there's a lot of promise.
Mm-hmm. Yeah, I think in the US that would be helpful for rural areas where we just don't, yeah, you just don't have that much data sometimes.
Okay, cool. Daniela, do you want to ask the question?
Okay, I can do. Thank you for all inputs here and very inspiring dialogue. My question is mostly about the parallel with what we call generic drugs. And I'm thinking if it is to start much earlier, to think about this, everything what is around AI. And yeah, that is mostly, and if it will be time, I would like to ask another question about electronic medical records, but I think that is not time, and I can write a note to David. Thank you all of you, and good luck with this group. Thank you.
Adriana?
I think David wanted to come in first.
Well, I was just going to say, relative to what Daniela said, one issue is, you know, when it makes person-specific predictions, sometimes the AI can't tell you why it did that. And that then puts clinicians in a very difficult spot because the computer is saying something. But like, you know, like if you look at the like CNN type convolutional neural network type stuff, it can't tell you which part of the image it really used to make that determination because it's gone through 7 layers of processing and so on. And I think that kind of personalized thing can make it be very difficult because then the computer says, well, I think it's X. And the doctor says, how do you know that? And the computer says, well, I can't actually tell you that. Like, that's not a question I know how to answer.
I agree totally, and I'm coming from cybernetics in my ground, and I agree totally with you, but I'm thinking mostly about this regulatory and especially about these companies who aim to have profit, and you know what I mean, like the same in the way what we have the development with pharmaceuticals. Thank you.
Okay, we are approaching the end of our time. So just quick announcement that Divya will probably make some happy hour announcement for those who are attending you here. And I will try to make some arrangement for happy hour for our group during ASH Econ. So stay tuned. We're gonna be following up. And this last 1 minute, how about let's have our 2 speakers each share 1 or 2 sentence summary about what are you looking forward for researchers in this area moving forward.
So I'm definitely looking to expand working on digital health, all aspects, including AI. And the most exciting thing we're trying to do now is organize an RCT around augmentation of diagnostics in primary care with AI. But I think there's so much work, and I'm very happy to engage offline with people about who have data or ideas about other things we can be doing. This is a wide open field.
I have done a machine learning prediction, and my machine learning model has concluded that this is a fantastic area for people to do work in. So when people do work, please send me copies of it. I'd love to see it. And I think the field needs as much work as we can do.
So thank you so much for our speakers, and thank you for everyone
you.
who's attending. And can we also get a copy of your slides for today? If so, we're also going to post the slides together with the video, so you don't need to do the snapshot around the hour. Okay, thank you. Take care, everyone.
Thank you.
Thank you very much.
Thank you.
Thanks,
Bye,
everyone. Thanks. Bye.